Thank you so much, Priya. While we're getting this, I just explained the benefits of the risks. There weren't that much risks. We routinely exceeded patient expectations. I didn't realize it would be that fast, that quick, and so forth. But now, I'm also a refractive surgeon because every single one of my IOL patients has options. They're self-paying for this option. And of course, now they want to hear all the options. They want a chance to ask all the questions. And you know that expectations are key. And, I think we all faced a little bit of an initial turnoff in terms of, wow, we have to spend all this time talking about these options, setting the expectations. There's the unpleasant logistics. We're not comfortable discussing fees or collecting the fees. And, well, now we create these expectations that may not be met. We have a different reason for people to be unhappy with us. And, I'm not really comfortable with this financial conflict of interest when we have to market this and sell these options. But this is the trend, and we're going to see a dramatic increase in toric IOLs. And I think most importantly, we're going to be much better at treating astigmatism with the lens implants. This is just some data looking at the statistics. And, 3 out of 4 have at least some astigmatism, but, 36% at least a diopter. And in this day and age, certainly worth offering them that option. Now, value. You have to talk, what's a toric IOL worth? I mean, that's a question that you have to think about and you have to be comfortable with before you raise this and recommend it. And in every part of the world other than in medicine, value is based on what you would give up to get that benefit. So what would you give up to, well, here we have the most successful operation in the world. It's the number one cause of blindness, and yet we have a 98 or more % success rate at eliminating it. It's the highest volume procedure. And so when you do these calculations based on present value, it's actually about $95,000 US is what a cataract surgery is worth to the patient's life. You can compare it to treatment of breast cancer and a myocardial infarction. And yet the actual cost in the United States is so much less than its value. So it's what would you exchange to have a progressive blinding condition permanently reversed? Well, that's what you and we do every day when we do cataract surgery. Now, the trouble is that the buyer is usually a government. And so here they look at this, the highest volume, most expensive cost to the healthcare system. And there's no way they can afford the value. We just said it's $95,000. So they set the price. The patient doesn't participate. And cataract surgery is a commodity. So this refractive premium IOL channel is not medically necessary. And it requires much more than the technology, doesn't it? There's a lot of our services, and most of all, our cognitive, our experience, our judgment that is going into this. And so for the first time now, the patient has a value proposition. Do they want to pay extra for a refractive benefit? And since they enjoy the benefit, they pay for it. And this really does reward excellence in all of the top categories. And it's a way to differentiate the refractive from simply the cataract. So a refractive cataract surgeon is different. Well, sure, you have to have the skills. This won't work if you can't reliably do cataract surgery well, astigmatically neutral. You have to have all these diagnostic skills to know who should get a multifocal versus monovision versus a toric lens or LRIs. And we now need really good communication skills because we really need to be able to tell patients what this is doing for them so they can ethically, determine whether it's worth it for them, not just because you, the doctor, have told them, you should do it. So we have to set expectations. So back to the government. The way in the United States they determine the value of things is by time. How much time does it take? And so as we have made our procedure better, it's worth basically less. And surgeons have no choice in the United States, like in most countries. This is what the government pays. And we respond by doing more surgery and spending less time with patients, increasing volume. So if you look at astigmatic keratotomy in this paradigm, it adds less than a minute of time to the operation, no extra supplies. It shouldn't be worth anything in terms of the government, and yet a modest fee, what an American patient would pay, it's actually 50% of what the surgeon gets to do the surgery. So, restoring value, it may add 1 minute, no extra supplies. That's what the government might price it in the United States. And yet, for an American patient, they would look at that and say, that's nothing to, get a lifetime benefit in terms of astigmatism, and realize that they're not paying you for your time. It's not a minute of time. It's the interpretation of the diagnostics, your experience, how many thousands of these have you done, and also your ability to communicate what the value is and to help them decide whether it's worth it. Same thing, a multifocal lens, the value for the surgeon, I guess, could be zero. It doesn't take you any extra time. There's no extra supplies. But there is plenty of value that you add. The testing, the evaluation. And this is really, to me, what the patient pays a lot for with a multifocal. Yes, there's some cost to the IOL company, but there is no substitute for the knowledge, experience, preparation, the clinical judgment, compassion, and integrity. And that is what differentiates me now from when I was a resident. And that is where the value is. So think about that. And this is what you need to do then to be a refractive cataract surgeon. You've really got to do a good job of educating patients. You've got to be efficient or this will take forever. And you really have to do everything to the most excellent degree, which includes the testing, things in the operating room, to try to get the best results. And what I'll talk about now is just some pearls for this part. Evaluation, patient selection, counseling. Okay? This is where you can be great, you can be good, you can be mediocre, and this is where the premium is. It's not the cost of the lens. So, in my practice, it's consultative. I don't do anything except IOL surgery. So they get a handout in advance before their appointment, explains that there are these options for out-of-pocket upgrades. We ask a questionnaire. They can communicate to me in advance how desirable it is to reduce their dependence on glasses. We refer them to a practice website because then I can control the experience, the information. I don't want them reading other patients' blogs about what lens they wanted and why they chose it and so forth. That's no way to decide. And on this Dell Questionnaire, I ask this question: where are you on the scale? Prefer glasses all the time? Hate glasses? And when the patients see, there it is at the bottom, when they say they hate glasses, okay, then I know we really have to look at what's the best solution. So this is something you can get in advance. And the problem with multifocals, and this is really important, if you look over here in the yellow, that's the restore and the techness, the yellow and the brown. And if you look on the left, that's depth of focus. And you want a high depth of focus. And then you look at the bottom, and when you go from 0 to a half diopter of astigmatism, you drop the depth of focus and the quality. So the reason I use toric so much is if I can't get the astigmatism to less than a half, I won't put in a multifocal. It's as simple as that. You already are compromising too much. And this is just some data. It's the only study, believe it or not, that looked at how successful we are with multifocals and LRIs. One study, that's it. And 29% of the patients who had an LRI still needed LASIK. Okay, well look at this. After LASIK and LRIs, you still had 20% basically that didn't hit 20/25 and J1. Not very good, and those patients are unhappy. So if I'm looking at 1 to 2 diopters of SIL, I'm really thinking toric or astigmatic correction with a monofocal frequently, although obviously there are a number of strategies. This is just a paper that shows that for higher amounts of astigmatism, torics work better. And I think the problem with most of these studies is you've got to look long-term. And as you look long-term, you'll see that astigmatic keratotomy regresses in many cases. That makes sense. And looking at the cylinder within the first 3 months, you miss that regression and hence torics. So here's a patient pre-op multifocal. But look at their cornea, it's a little irregular. I'm going to put in a toric because they've got too much cylinder. This is, the eye trace is kind of neat because if you look at the lower right, there's something called the refractive power where you're measuring the central 3 millimeters of the cornea. You're using 600 ray traces, and from that calculating the composite, the net astigmatism, whereas in the bottom, it's a Simk. It's that 3 millimeter ring. You're only looking at the 3 millimeters. So what's neat about it is if you look at the 3 millimeter ring here, you only see 0.3 diopters of astigmatism. You're missing that little butterfly bow tie in the middle, and you can miss that. So the refractive map, very useful there. So again, topography in combination, very important. Now, communicating to the patient the value. I mean, the last thing I want to explain to people is astigmatism. They just have trouble really getting that. So what we do is everybody gets topography in this wavefront. We do it on the eye trace, and then we are networked to every exam room. So we can put that up there. We also do the IOL master in advance. We upload it to something called Forum, but there are many different software management things. And so this is in the exam room, and I can show it to the patient. And if you're going to try to explain astigmatism, I think you want to show the topography. And this is what I was going to say. So it's a diopter and a quarter, and I explain the topography, and I explain that, what is astigmatism. The first thing I'll say is this is your cornea. It's a map of your cornea where each color is a different curve. So we want it to be all one color. Ideally, it would be all green, because that would mean like a bowling ball, your eye is the same everywhere. Your eye isn't all green. Your cornea has all that yellow, which is a different curve, and the yellow and the green focus at different places. I don't have a cataract, but if I put your cornea on, I'd go, whoa, things just got blurry. But I could put on a pair of glasses that would then make it sharp again. I explain to them what their options are. I say, insurance will cover the basic lens. It's a great option. People can pay extra out of pocket if they want to upgrade for certain advantages. The most expensive, I tell them, is a multifocal, and it costs X. And it's for far and near, but with this amount of astigmatism, it's probably not going to work very well, and I wouldn't recommend it. So you'll get a single focus lens. The single focus lens, though, we can upgrade. We can take the amount of astigmatism that your cornea will need to be treated in glasses, we build it into the lens, and then we call it a toric lens. And what it allows us to do is a little more of a custom approach for the lens for your eye. It's still a single focus lens, and you will pay this amount extra, and it's less than a multifocal. It helps to compare it to a multifocal. That's called framing. You emphasize there's no added risks. You emphasize the expectations. If you want to see well in the distance, you're still going to need reading glasses. Your distance may not be perfect. And I always tell them the cost, because I basically want to see if the patient is disturbed or bothered or, basically feeling that that's too much, too costly, and if it is, then we come up with a better option that might be astigmatic keratotomy, that would be less. And I try to make it as comfortable as possible in terms of leaving the patient with the idea they're going to get the best approach for them. You hate to say, this is the best option, oh, I'm sorry you can't afford it, that's too bad. You sort of always end with, well, you're going to see great with cataract surgery. You're going to see really well with glasses, and even without glasses, it may not be so bad. But that, in essence, is how the conversation goes. You got to be careful about overpromising. We don't do that. That's why I find that it's better for me to discuss the cost, and then whatever we've decided, toric or astigmatic keratotomy, I will then give them a handout that I've created that sort of reviews a lot of the things that I want to do. I've written a book. Basically, becoming a refractive cataract surgeon, though, I think has become very important. We're fortunate that we are able to do things that are no longer just purely medical, that are refractive, and it actually does allow the patient to determine the value of something. They can decide whether they want it or not. And it forces us to strive not just for surgical excellence, but for practice excellence in terms of our evaluation, our service, and our communication. Great. Thank you very much.